bit in the next chapter of pathology, just a tiny bit. And really, we're going to review some stuff. So I'm going to give you a homework assignment on fractures from Bontrager. So I want you guys to know those. I have a worksheet with all of them labeled out that you are welcome to go through and fill out. Or you can use your own sheet if you want to, but it's going to be a homework assignment due Monday.
Is this going to be, this information on fractures going to be included on pathology?
Yes. Yes. Is the information on fractures going to be included on the pathology exam? Yes. Yes. Want to make a list of what's going to be on the exam?
Sure, yes.
All right. Let's make it. Just so I can proof my exam too.
And our resumes are due on the 11th.
Yes. Resumes are due on the 11th. I don't know if anybody has submitted yet, but I did put a link on Canvas. So you're welcome to submit if you want to. I've had a couple people email me resumes to kind of proof or give them to me in person. If you want to do that, I want that before Friday. Okay, so if you send it to me next week, I'm not looking at it. I'll say, please use the submission tab on Canvas. All right, so resumes on the 11th. Let's talk about the exam next week. All right, pathology exam. So terms from chapter 1. Common pathology, I'm sorry, I'm skipping a chapter. All of the specialized imaging techniques that we talked about in chapter 2. So all of the modalities, CT, MRI, PET, SPECT, nuke, X-ray, ultrasound, how they work, if they're ionizing, how the image is produced. Okay. Chapter 2.
So how they work.
Can you say that one more time?
Yeah. So chapter 2, modalities, it's called specialized imaging techniques. So any technology that we talked about, so any modality, so PET, SPECT, nuke med, ultrasound, CT, MR, X-ray, mammo I think is in there. All of those specialized imaging techniques. So how they work, how the image is produced. If there's like specific equipment involved, I think about like gantry when I think about CT or MRI, or a mammography unit when I think about mammo, an X-ray unit. Is it using a radiopharmaceutical, something that's radioactive in the body? So I'm thinking about like SPECT or nuclear medicine, so make sure you know that. Is it ionizing radiation or not? Is it ionizing radiation or not? Definitely want to know that. Yes, do you have a question?
I think I struggled in that section because there is a lot of information and I don't really know what is like, what we don't need to know, I guess.
Okay. Is it ionizing?
So like just this list.
Yep. Is it ionizing? How is the image produced? How does it work? So does it use a magnet? Does it have a gantry? Do we have ionizing radiation that's producing an image? Do we use a radiopharmaceutical? So things like that, yeah. That's what I would focus on. Be able to identify and distinguish between the modalities if I'm describing one specifically. So ionizing radiation using cross-sectional anatomy. CT, good. Non-ionizing radiation demonstrating cross-sectional anatomy. Good. Without a magnet. Ultrasound, good. So get specific, okay? You probably already know them. So chapter 2, modalities, review those. Chapter 3. So here's where chapter 3 gets fun. When we talk about the respiratory system, I could potentially include anything from a positioning class about chest. Okay, so anything. Why do we perform a left lateral versus a right lateral? Why do we perform a PA versus an AP? So I will get specific with chest positioning. So if you need to review that, I would do that. I would do that probably today or tomorrow, okay? Review your chest positioning, your chest anatomy. So I could ask you to identify any part of the chest on a radiograph or on a diagram. I like to kind of recap here because it's been a long time since you talked about chest and abdomen and extremities. So as we go through these pieces in the pathology book, it's more pertinent and important that we cover information that's going to be on the registry than to bog you down with a lot of pathologies that you won't need to know. So for pathology, you want to stick to the specific ones that I gave you on the list and the specific ones that we talked about in your book. Remember, you're not going to read through the entire chapter 3, only the ones that we talked about. So hopefully you took good notes when we lectured through all those pathologies. So chapter 3 is going to be chest pathologies covered. And you can think about it as Bontrager chapter 2 if you want to freshen up on your positioning. Bontrager chapter 2, positioning and anatomy.
So that's also gonna be scanned on.
Yeah, stand on, yep.
I have a quick question.
Yeah.
With the specific pathologies you wanted us to focus on, did
Uh-huh.
you hand out a piece of paper?
I did.
I listened to the lecture and I assumed it was something you handed out.
I did. I'll give you one upstairs. Come see me after. It's just this.
I can see a picture of
I think it's online too. Did I post it online for you guys on Canvas?
I'm not sure.
I don't think I saw it.
Okay.
I might have looked past it.
For pathologies, the ones we discussed in the
Yes.
book and in the notes, do we need to be able to identify the images, or we know?
No, not the image. So you do not need to be able to identify the pathology on an image. I'll probably describe it.
Just know.
I will probably describe it. There were only a couple that we talked about image appearance, right? So we talked about like pleural effusion, blunting the claustrophrenic angles. I could maybe include an image on that. Or another easy one would be pneumothorax. Remember pneumothorax, absence of the lung markings. Absence of the lung markings.
So that'll be kind of like defining what it is,
Yeah.
and then characterizing, like you said, the blending and
Yeah.
stuff like that.
Yep, exactly. Exactly. All right. Ooh, the tubes. The internal devices in chapter 3 you need to know. So the ET tubes, the CVCs, so central venous catheters, PICC lines, Swan-Ganz. So make sure you review those. They're on page 40 and 41. 40 and 41.
You said pig lines, swans.
Yeah, they're all on here under internal devices.
All of them.
Internal devices, page 40 and 41. So ET tubes, CVCs, PICC lines follow under CVCs, Swan-Ganz, and the last one is a pacemaker. All right, and you guys already know the specific pathology that we went over. You could probably use this as your guide if you don't feel like your notes are very good for the chest pathology. So use your common chest pathologies. For the next chapter that we are going to be going over today, we start out in skeletal. Like I said, we're not going to go very deep into this information because there's a lot of different terms regarding fractures, which we don't need to know all of these for the registry. So we're going to stick to the ones that we need to know. That's why we're going back to Bontrager for those. So for your homework, I want you to use your Bontrager book because that's what I paired it with. Okay, it's fractures from Bontrager. So that's it from chapter 1, 2, and 3. I won't ask you any extremity positioning because we haven't really talked about that. I could ask you skull though, okay? I could ask you skull or facial bones. So today I'm gonna go up in the lab and demonstrate facial bones. Hopefully you did your homework. If you don't have information written down somewhere that you can show me, you will not be allowed in the lab because I'm not gonna do the work for you. Yeah?
In chapter 3, there is a diseases, and after that, image appearance and treatment.
Image appearance and treatment for,
Yes, after disease, every single disease, respiratory tract.
for chest?
Yes. Do we need to know the treatment?
No. No, good question, no.
So,
I would stick to the information that we went over specifically. So describing it, if we're talking about, let me think of one that we talked about here. Croup on page 44. If I was to give you, I could actually describe it to you, or I could give you a situation like a scenario. So I could say a young child came in and has been diagnosed with a pathology that produces inflammatory obstructive swelling localized to the subglottic portion of the trachea. This is specific to a barking cough. So would you be able to recognize it, basically? Yeah, croup. Croup specifically. Yeah, so only the ones that we went over though, okay? Another one, hyaline membrane disease. So this is a pathology that is common to newborns that are premature. The lungs are sticking together due to the lack of surfactant. What is this characterized as? Hyaline membrane disease. Yeah. So just specific descriptions of the pathology, never identifying it on a radiograph unless it is pleural effusion or pneumothorax. Those two you should be able to distinguish.
Our exam's on the 13th, right?
Yes, 1 week from today, next Wednesday.
For the skull and facial bones that you could test, it'll just be this.
Yes.
Okay.
Just be the information on your matrix or whatever you decided to make for note-wise. So just the information that I required you to know. So any kind of positioning, maybe the line that you're going to use for positioning or part position. So are you able to do a left or a right lateral for a skull? Yes. Which line do you use on a PA0 skull? I'm just trying to like make up questions in my head right now. But think about it like that. What's the exit point or what's the CR? So just the information on the matrix that you should already know because you did go through skull positioning, but we're recapping. And since we're using that time in class to recap, I want to test you on it. Okay, so just skull and facial bones because that's what we're going to finish today. So just skull and facial bones.
And then chapter 4, pathology, will be on this exam.
Chapter 4 will not pathology specifically. So I'm just going to go over a very, very small amount, only the information that we covered today.
And it will be on the test.
It will be on your exam in 1 week, yes. It will be on your exam, as well as fractures. Fractures.
Fractures in chapter 4, that's in the Bontrager review.
Chapters for Bontrager specifically that I give you. I'm going to post something on Canvas.
We're having on Wednesday.
Yes,
Okay.
1 week. As well as joints. Joints from Bontrager. Joints. So if you don't know them, review them. I have a page number written down somewhere. What is it?
Talking about the test next week, correct?
Yes, Wednesday. Joints.
Fractures and joints will be on the test next week.
Yes. I think it's pages 11 through 14 in my Bontrager, but I have the new one. So it's pretty close. So 11 through 14, joints. Make sure you review these. Like I said, you should. Bontrager.
The new one that we have, the green one or the blue one?
Either one. Either one.
Like page number.
Oh, no, I have the gold one.
Okay, 11 through, so the synovial and.
Mhm.
Is it under?
Diarthroidal.
What's it under the chapter?
Chapter 1.
Oh, okay.
It's chapter 1.
Gotcha, it's page 11. 11 to 14 and
11 through 14 in the green book. So make sure you review this. Classifications of joints.
Will you go over what, the test is gonna have from chapter 4, just so we can write it down?
Well, I'm about to go through it. I'm about to actually go through what we're gonna have on the exam. But it's just a couple of pathologies and basics of bones. And that's all we're going through before we go into the lab. All right, so everybody ready to talk about chapter 4?
Yes.
Any other questions for the exam?
You haven't given us our homework yet, have you?
No. Homework is gonna be on Canvas. As soon as you leave, I'll post it. Your homework is going to be on fractures. Bontrager fractures, that's gonna be your homework. It's gonna be due Monday at midnight.
And then the stuff we go over today in chapter 4 is on the test.
Yes. We will not finish chapter 4 today, though. It's very lengthy, it's very bogged down. I'd rather focus more on positioning aspects than all of the pathology that's demonstrated. All right, is everybody good? Does anybody need a break before we start chapter 4?
No.
Okay.
One quick question about the joints. Are you wanting to know,
The
how they move?
classification and the movement.
Okay.
Classification and the movement, good. So is it synarthroidal, is it diarthroidal, is it synovial? And what classification or movement is it? So is it a hinge, a ball and joint, a ball and socket joint, saddle, cellar? I'm just thinking about all of them for review.
Thank you so much.
Yep, good questions. All right, chapter 4. Chapter 4. So we're gonna start out on page 87. Start out on page 87. So the very beginning of this chapter, the first column, I have a fill-in sheet that I'm gonna give you. When you're not in the lab, you're gonna be filling this out. It kind of gives you a hide and seek kind of thing, just to pair these terms. So oppositional growth, compact bone, diaphysis, endosteum, epiphysis, cartilage, medullary cavity, metastasis, ossification, osteoblast, osteoclast, periosteum, reabsorption. So these are terms that you need to know, but they're all covered in this first section. I don't want to read through it because it should be kind of common knowledge from the bone chapter. So from upper and lower extremity and Bontrager, but if you need a refresher, it's a good thing to do it. Those terms will be on your exam. So any of those terms are fair game. All right, so let's start out with the two terms that are listed on this second column on page 87. They talk about osteoblast and osteoclast. These are your basis for your pathology for skeletal. So these are your basis. You need to know what these two cells are. So the osteoblast, they create the new bone. It says osteoblast create the new bone. Osteoclast remove and absorb bone. So that's the difference. Osteoblast, so think they're blasting out new bone. Osteoclast, remove or absorb bones. These are how bones are grow. These are how bones are able to grow and expand in size due to the osteoblast or clast. Specifically, when we start talking about the pathologies, they'll say there's a deficit or a defect or an overabundance of these cells. This is how you're going to be able to comprehend it. So if it's a clast, it's removing and absorbing the bone. So if there's a defect in it, you're going to have an abundance of bone. If it is a, I don't know which one I talked about, blast. Okay, if it's a blast and it's producing new bones or new growth cells and you have an overabundance of it, you might have growth outside the bone. So this is how we classify pathology specific to the skeletal system. The second paragraph, they start discussing something called a bone age study. Who has performed a bone age study clinically? Yeah. So what do?
Literally everything.
Take a picture of the left hand. It's pretty easy, right? PA left hand. Usually they specify it to a certain size. It's department protocol. It doesn't have to be the left hand. There's nothing special about the left hand. It's just the way they keep it consistent. So this bone age study, if you haven't seen one, is specific to predicting adult stature. So if a person is short, and maybe they're like 14, maybe they're 15, and they're about to stop growing. If they're short, they might do one of these, or if they want to know if the growth plates are sealed or not. So you can see the growth plates on the long bones. So if they take an exposure and they include the wrist, which they should if they have a hand x-ray, we're able to see if the person is done growing to determine their stature, predict their height, and to see if their growth plates are sealed or not. All right? And it tells you a specific kind of encyclopedia. They call it a Grulich and a Pile. This is an atlas that was compiled where basically two radiologists got together and said, how do we determine if a person is going to be this tall or not? So they started imaging everyone's hand, all right, so within the growing period. So the person would have to be under 18, primarily under 16 is what they prefer. So under 16 years of age. They started taking a picture of everyone's hand to see and determine how tall they would be. So it's an estimation used from a correlation from a person's x-ray and their actual growth throughout their life. So it's just kind of like an atlas or an encyclopedia. They are the people who discovered that we could take a picture of the growth plates and see or determine in an estimation of how tall someone would be, or if they're having short stature or statue issues. All right, so you definitely want to know this term ossification. So it is known as bone formation, ossification. So which cell is going to be paired with that? The blast. So bone formation is paired with the osteoblast. Remember, blast, new bone, we're blasting out new bone. So ossification, bone formation. The other term is resorption, and it is paired with an osteoclast. Because it would be absorbing. It also tells you that around the age of approximately 40, you are going to start experiencing bone loss, and this is going to make your bones eventually look like hollow tubes. So it's just going to be like a hollow shell. They'll start to decrease in calcium, and you will be at a higher risk of a long bone fracture, as well as you will be less resistive to compressive and bending forces, and you will have loss of height of your vertebral bodies. So basically after 40, everyone's going to break bones and have back pain, right? Everybody probably already has back pain, right? Fun stuff, getting old. fun stuff. So you will see, I'm sure you've seen some jacked up spines, x-raying them throughout your clinical time, but not an uncommon thing, especially here in America, to have back pain due to life, right? Okay, so the other terms on this page in blue are covered on this worksheet that I'm going to give you. So I'm going to have you go over those individually, but the ones that I'm hitting on specifically, you want to focus for your exam. As well as, turn the page to page 88. There's a nice green box here that talks about the 5 basic functions of bones. So we want to know these if we don't know them already. So let's go through them. Number 1, bones serve as the as the supporting framework of the body. Obviously, our bones support us. They make us able to stand up or sit down, stretch out, bend, flex, extend, all those good things. They also protect the vital organs. Example, the skull protects the brain. The rib cage protects the heart and the lungs. Obviously, our bones are protecting our vital organs. That's why they are designed this way. Bones serve as levers on which muscles can contract and shorten and thus produce movement at a joint. So they serve as movement or levers at joint spaces. So think elbows, wrist, knees, ankles, good things like that. Movable joints, they're serving as our levers. Red bone marrow within certain bones. They give you the specifics. Spinal cord, upper humerus, upper femur in the adults is the major site of production of red blood cells. So you don't need to know the site specifically, but I would know that the production of red blood cells happen in the bone. If you don't know that specifically, I would know that the red blood cells can be deficient if you have some kind of an injury to a bone. Specifically, they're talking about long bones here, so most of your red blood cell production is going to be in your femur, in your hip or your pelvis area, which is not a long bone, or your humerus. So specifically, anybody ever seen a spinal case where they dug out somebody's hip to assist with it? No? No? Long spinal case, so think neurology. If the person is prone, they will have their back opened up, and to complete a fusion, they will kind of hammer into the person's hip, remove a little bit of the bone so that there's natural red blood cells for regrowth, and they'll pack it into the spine. So I've seen it a lot. It's not a very comfortable procedure. So when the person wakes up from their spinal surgery, they're going to be sore already from having some kind of fusion, and then their hip is going to be sore as well. But it's a really good site to promote new and natural growth, and it accelerates in the healing process. So you might see that clinically. All right, so I want to skip over to page 90 and talk about osteopetrosis. Remember, the chest pathologies, they don't really have additive or destructive pathology types as far as technique goes, except for very specific ones, like if we're introducing pus or some kind of fluid to the body. Of course, we're going to increase if we have fluid where there was air. As far as a pneumothorax, we already had air in the lungs, so if we have air in the cavity now, it's not really going to increase or decrease our technique much. But when we talk about these skeletal pathologies, we do actually modify our technique if they are present and we are aware of them before we x-ray the person. So specifically, osteopetrosis is also known as marble bones. This is an important one. So it's a rare hereditary bone dysplasia in which the failure of resorptive mechanisms of the calcified cartilage interferes with the normal replacement by maturing the bone. So basically, it's preventing the bone marrow from forming, so the bones become very brittle and stressed. But due to the lack of reabsorption, are we going to increase or decrease our technique? Increase, good. So osteopetrosis. So think you're kind of calcifying somebody. Osteopetrosis. Kind of sounds like a Harry Potter term, right? So this one is going to be an additive. So this is an additive pathology. So we would increase our technique if we were aware. If we are aware. I've only seen this one time clinically, but I've seen many mock registries that will throw this one in there with osteopetrosis and osteoporosis to see if you know the difference between which one is additive or destructive. So a little play on words. So make sure you read the question very carefully when you're answering this. So osteopetrosis, The failure of reabsorption, even though it does debilitate the bones and make them brittle, it is still going to make us increase our technique, okay? Increase our technique. The second one we want to talk about is on page 91, osteogenesis imperfecta. Anybody seen this clinically? This one's a more common one, a little bit more common one.
There's not like that.
Not like that, maybe. You probably wouldn't have seen an x-ray of it, but if you got a chance to go through a Wolfson rotation or you got a chance to go through any kind of a NICU, you might would see this. So it is called brittle bone disease. And it is an inherited generalized disorder of connective tissue characterized by multiple fractures. So this person's going to have a lot of fractures all over their body. Something specific physically that you can see is the sclera, which is normally the white part of your eye, is going to have a blue hue. And it's due to imperfectly formed or inadequate bone collagen. So bone collagen. So usually these people are wheelchair bound if they make it that long. The prognosis is not really good, but the skeleton is not even able to support the own weight. So if you ever do see one of these, you'll see a lot of signs. It'll say brittle bone. It normally won't say osteogenesis imperfecta, but I'm thinking like NICU wise, if you see one of these babies, it'll say brittle bones all over the kind of incubator that the baby's in or around, because you won't be able to move the patient. You'll have to have like 3 people move like a 5-pound baby. And you think, that's ridiculous. The baby weighs nothing. But you have to move them very, very carefully or they could have a fracture. Hard to sustain the lungs because of constant rib fractures. I've seen patients that have had rib fractures just from breathing with this disease. So not a good prognosis here at all. They give you a picture of it. I've never actually shot like an extremity to see like the density of the bone, but I've done chest x-rays and abdominal x-rays on these patients. But not a good disease to have. Do you think it's an increased or a decreased additive or destructive pathology? Destructive.
Life expectancy, like, do they make it to like toddlers?
So I've seen like a 3-year-old. I've seen a 3-year-old. That's the oldest person that I've seen that has had it.
So do you decrease technique on that?
Decreased technique on brittle bone. Why? Because there's not as much to penetrate. There's no bone collagen. So,
Anytime there's destructive, is that usually decreasing?
yes. Yep. Anytime it's a destructive pathology, we are going to decrease our technique. The next one, we're almost through it, guys. Almost through. It's just a couple for this chapter. The next one's on page 92. Achondroplasia. This is also known as dwarfism. So fancy word for dwarfism. I have seen this word on a mock registry more than once, so make sure you know it. Achondroplasia, and it's the most common form of dwarfism. So it results from diminished proliferation of the cartilage around the growth plate. So basically the person is not able to grow, right? They're short. These people have longer life expectancies and good prognoses, but they're just not going to be as tall as most people, right? I don't need you to know any of the characteristics for the facial features. You will notice though, if you've read these and then you actually see somebody with this disease, maybe out in public, I don't know if you've seen a dwarf, they have a lot of these. So saddle nose, a jetting or a protruding jaw, or a prominent buttocks that gives the false impression of lordosis. So because they're so short and they're not able to grow, they just kind of grow out like this a little bit. But you might have a dwarf in your family. Anybody know anybody who suffers from this? No?
My regulars, like Pepper
Yeah.
he is.
Yeah.
It's super nice.
Yeah, I know a couple people with this, but life expectancy is good, not going to affect anything long term. It can get kind of complicated as your organs are growing because they don't have as much room to fill up things, and muscle tone is usually decreased in this disease due to the actual ability to grow and size. But life expectancy is good. Make sure that you know the actual term though. Achondroplasia is known as dwarfism. So make sure you would be able to identify that. Another one we want to talk about is congenital hip dysplasia or dislocation. This one is a very common one in peds. You will see them use ultrasound specifically for this. This one is a developmental hip dysplasia that results in an incomplete acetabulum formation caused by a physiologic and mechanical factor. So where's your acetabulum? Acetabulum, right back here. Acetabulum. So incomplete formation of this. This results in hips that are bowing. Pediatrics will see these if the toddler or the infant that started walking is kind of like walking like this. They probably have hip dysplasia. So if they're kind of limping when they first start walking, you can notice it. Also, people who have 2 different size femurs or 2 different size tib fibs, if one leg is longer, it's common for them to have a dysplasia or a dislocation because they're not using the joint properly, right? But know that we can identify this one with x-ray or ultrasound for sure. This one can actually be diagnosed in utero. So when the baby is in the womb, if they ultrasound the patient and they're able to see all of the bones that are visualized, they can actually diagnose this before the patient is even born. To diagnose this with an x-ray, we would just do an AP and a bilateral frog leg. Anybody seen a dislocated hip? Yeah. Yeah, good prognosis. They can correct it with surgery. They can also correct it with physical therapy.
I have a question.
Yeah.
Achondroplasia, I don't know if I'm saying that right. For
Uh-huh.
dwarfism, so the bones are gonna look a bit thicker, so it'd be additive.
Yes, achondroplasia, additive. Good, sorry, I didn't tell you guys that. Increased or additive. Why? Because the bones expand less. They have less oppositional growth, so they're thicker and more dense.
So additive.
Additive. Additive, good.
Technique.
Additive and increased technique. Yep. Additive pathology, increase your technique. Congenital hip dysplasia, not an additive or a destructive. It's not going to change the way we image someone just because their acetabulum is not developed properly. It's just a joint issue.
I have a question.
Yes.
When you see someone that has like brittle bones, you don't ever wanna go in the room like by yourself.
Right.
Because, so if we were to go, we would make sure the nurse and everyone would, so you need at least 3 people?
Yeah.
Okay.
Yeah, I would say you need at least 3 people, but they're going to know that as well.
Okay.
So if you're ever in a NICU environment, you're going to have lots of respiratory therapists around, lots of nurses, lots of CNAs, so they will be more than willing to help you. Also, the use of the bed in the NICU that just pulls out underneath the patient is very helpful because you won't actually have to move the patient if you're able to use that. So that's a good thing too. But still consider things like shaking, like if you pull that out and it shakes the patient at all, very small movement. So if you can break a rib by breathing, just by shaking the incubator or the bed that the baby's in could definitely damage the body. So just be really careful.
Achondroplasia, is that a destructive
Achondroplasia increased.
increase?
Mhm, additive.
So additive. And then hip dysplasia is additive as well.
Hip dysplasia is nothing. Hip
Nothing.
dysplasia is nothing,
What?
yep. So congenital hip dysplasia or dislocation, neither additive or destructive. The acetabulum's not formed properly, but we're not gonna change our technique. It's just gonna be a joint issue for the patient. Okay, so they still have the same bones, it's just not formed properly, but we're not gonna add or decrease our technique for this specifically. Good question. All right, I'm sure you know somebody with this next pathology on page 95. 95, rheumatoid arthritis. My grandparents have this. I'm sure you know somebody who suffers with this personally. This is an inflammatory arthritis. They call it non-superlative, meaning non-infectious. Sometimes when you see that term superlative or non-superlative, think of pus. Okay, think of pus. However, this is not infectious, meaning you can't give it to anybody else. It's non-contagious. Non-infectious. Women are affected 3 times more frequently than men. I would know that. I would know that for sure. For rheumatoid arthritis, women are affected 3 times more frequently than men. And the onset average age is 40 years old. I would also know that. So what happens as we age? Our bodies just don't work the same way, right? They just don't work the same way. So in the second paragraph, it tells you how it works. So rheumatoid arthritis begins as an inflammation of the synovial membrane, so they call it synoveitis, that lines the joints. The excessive joint fluid results in an inflammation, causing a proliferation of the synovium. The resulting mass of thickened or granulated tissue, and they just define it as pannus, which means covers like a sheet, causes erosion of the articular cartilage and underlying bony cortex, fibrous scarring, and even the development of ankylosis, which is bony fusion across a joint. So what do you think? Do you think this one is additive or destructive? Additive or destructive? So we're torn here. Additive or destructive? It's destructive.
Oh, I got right.
Would pus mean that it is infectious? Good question. No, pus is not always infection. Pus sometimes can just be inflammatory and an inflammatory response. So if it says it is bacterial specifically or infectious, it would be pus relating to an actual stem from a bacterial or a virus. However, this one is created due to inflammation specifically. Good questions. So this one is destructive. They give you some nice images here. I really like figure 414. This is a very severe case. Know that when people have a lot or mutilating rheumatoid arthritis, their joints actually start to change shape. So you might see somebody who has like crippled hands, very uncomfortable, very painful, right? Everybody's probably x-rayed somebody like this or knows someone like this. Their hands are just kind of stuck like this. So not a very comfortable disease, but does not affect the lifespan, just decreases comfortability as far as living. All right, let's talk about osteoarthritis on page 98. This one is also known as degenerative joint disease. Probably know somebody with this one as well, osteoarthritis. So it's an extremely common disorder, characterized pathology by the loss of joint cartilage and reactive new bone formation. So reactive new bone formation. The picture that I love the most is on page 99. It's figure 423. So note the narrowing of the interphalangeal joint spaces. So this person really doesn't have any joints, so very, very painful to move. Additive or destructive? I would say neither. Neither. This one is associated with the loss of the joint space. Because it is called degenerative joint disease, if you wanted to classify it, you could say it's destructive, technically, because you're degenerating the joint space. But as far as increasing your technique or decreasing your technique clinically, you would need neither. This person is just going to have a really hard time bending. So when you do those fan laterals, you might have some issues. Their fingers are going to look more like straight, or they might be stuck in this kind of ball catcher's position. Osteoarthritis. So narrowing of the joints. All right, let's skip over to page 101 and talk about bursitis. Bursitis. All right, so this is an inflammation of the bursa, which are small-filled sacs near the joints that reduce friction. So basically your bursa, they are around every joint. They're really, really small. When they inflame and they produce more fluid, it is restrictive for your movement. So has anybody ever seen something called like water on the knee or water on the shoulder, where they have like a kind of blow up here or on their knee, they're not able to walk? This can be random, meaning the person could have taken it easy yesterday and then today they wake up and their joint is swollen. So bursitis, inflammation of the bursa. Additive or destructive? What do you think? We are having more fluid. Additive. Good. Additive. Additive. Questions that you might see on a mock registry related to this one would be specifically to shoulder and the knee, because those are the two common sites of bursitis. So inflammation, what happens to that sac when it overfills with fluid? It expands into the joint space. If you've seen an arthrogram, you may have seen where they reduce the actual joint fluid, where they just stuck the needle in before even introducing the contrast and drawing out some fluid to test it, maybe see the composition of it, or maybe just to relieve the person so that they're able to walk. Maybe just relieve the person. Let's go over to Bontrager if you have it and go over orthography real quick. So mine is on page 718. Raise your hand if you have not seen an arthrogram clinically. Good. Yeah, oh, one person? Oh, Heather. All right, 718. Raise your hand if you've never seen an arthrogram clinically. All right. Raise your hand if you've comped an arthrogram. All right, tell me how to do it.
Set up the tray with the medicine.
Set up the tray with the medicine. What kind of technique are you using? Medical asepsis or sterile?
Sterile.
Sterile, good. So we're using sterile technique because we're using a needle into the joint space. Just like I said, sometimes they would insert the needle and actually draw out fluid to relieve the pain. Sometimes they will just go straight into the joint and introduce X-ray contrast. Why do we introduce X-ray contrast first? Good. Good, to see where you're at in the joint. So remember, for this procedure, we're going to be using fluoroscopy. We're going to need to see where we're at, and to see if we're within the joint space under X-ray, we have to use X-ray contrast. After they introduce X-ray contrast, then we introduce what? MRI or CT, either one. You can do these under CT as well. MRI, obviously, you're going to get much more detail, much better imaging, but if your patient has limited ability to stand still or hold their breath, they may recommend a CT because it's much faster. All right, so then we're going to introduce CT or MRI contrast in addition to the X-ray contrast, but we also want to make sure that we always want to make sure that we confirm the placement of the needle to make sure that we're actually in the joint. Anybody ever seen contrast that was not in the joint? It kind of just expands out to the muscle and leaks out. So it should be specifically in the joint capsule, contained, and you shouldn't be seeing it drift off anywhere else to drain. So if you see it leaking, you're not in the joint space. What do you want to know from orthography for the exam and for going forward? I want you to know what it is. You probably already know what it is. It's a study of synovial joints and related soft tissue structures that uses a contrast media. So what's something that we need to make sure of if we're using a contrast media?
That they're not allergic.
Good, that they're not allergic. What kind of contrast are we going to be using for this?
ISOView.
ISOView. Okay, what is ISOView? Non-iodinated or iodinated contrast? Non-iodinated or iodinated contrast. It depends.
What's the one they use for CT normally?
For what?
Like if they do a CT with contrast?
I don't know. I can't think of the name right now.
The one that, I know it like burns a lot.
It can burn. Yeah, it can burn, specifically the joint area and the muscles. All right, so we are not going to use what? Barium, right? Everybody knows that we're never going to insert barium into a joint space, right? All right, so if barium is a choice on your test, don't select that, right? We only want to take barium in the mouth or the booty, right? So never in the joints. All right, so we want to make sure our patient is not allergic to the iodinated contrast if we use it. What is another way to word this to the patient?
Do you have any allergies? Are you allergic to contrast?
Do you have any allergies? Have you had a reaction to an iodinated contrast before? Do you have a shellfish allergy? Okay.
Yeah, why is it?
Why is it shellfish? Does anybody know? Iodine. Iodine in shellfish. So common reaction. Depends on who you're working with, radiologist or PA, if they choose to go forward with the procedure. Some of them will, some of them will not. But it is their call specifically. Remember, we always update the PA or the radiologist, whoever we're working with, before we bring the patient in and administer the contrast, just to double check.
712.
712. 718 on my page, sorry. So 718 and 719, but 712 on yours. They also talk about something that's common during the process to trauma called a Baker cyst. A Baker cyst. On my page, it is bolded on the second page. Clinical indications, a Baker cyst. So this is an example of a non-traumatic pathology process. So this is not due to actually movement of the joint, but it is similar to bursitis. So Baker cysts are specific to the popliteal area, which is the knee. Good. So a pathology that is specific to the knee that includes fluid. So a Baker cyst is going to be fluid filled. Are we going to increase or decrease our technique? Increase, good, if it was huge. If it's a small cyst, which it probably is, and you wouldn't even know that it was there, we're not gonna do anything clinically. Remember that we want sterile technique, because we wanna protect the patient from any form of infection. So we're gonna set up the tray. Do you guys run the fluoro, or do the PAs run the fluoro for this?
Some do.
It depends on what procedure and who's doing it.
Okay, what procedure and who's doing it? Probably depends on what joint. All right, so it does also tell you that a double contrast study is the most common. I have only seen air used very infrequently. Do you guys see air used?
In orthograms.
Mm-hmm. Yeah, I don't really see air used either. But it does tell you that double contrast study is the most common. So they're using some kind of negative and some kind of positive iodinated water soluble contrast.
I'm sorry, what is this Baker's cyst?
Baker's cyst under clinical indications. Clinical indications of arthrography, a Baker's cyst. So it's a non-traumatic, so it's not due to any kind of trauma or movement. But it is going to be fluid filled in the knee area. So that's why I wanted to talk about that. All right, I'm gonna close Bontrager. Questions about arthrography? Okay. All right, so let's stop with bursitis. We're not gonna go any further here. So of the information that we just talked about, any of it could be on the exam, but nothing else in chapter 4, okay? No positioning for extremities, nothing like that.
But the arthroplasty and stuff is just whenever, yes?
Yes,
And
orthography you need to know.
Okay.
Yes, I want to kind of recap with you. All right, so there is a sheet up here. This time I really want you guys to break up into, let's go ahead and talk about facial bones so I don't have to talk so much while I'm upstairs. Let's get Bontrager back out, or your notes. You will need your notes for the lab, so make sure that you have them. I'm going to have you guys walk me through it. Facial bones. All right, mine starts on page 422. All right, so we start out with a lateral. You can start out with a lateral. We can do a left or a right, depending on what? Protocol or effective side. So the effective side, we want what?
Closest to IR.
Closest to the IR. Closest to the IR. So we want to keep that in mind. So lateral left or right, we are going to use an 8x10 portrait IR. So 8x10 portrait IR. What is our SID? 40, good. Make sure that you have the patient walk up to the IR and then just rotate the head to reduce the OID. So we never want to have somebody standing side by side like a lateral chest. So walk forward and then just turn the head, rotate the head. All right, what is our CR here? Zygoma, good. Zygoma. So you should be able to feel, it also gives you another tip, midway between the outer canthus and the EAM. So midway between the outer canthus and the EAM, which is probably zygoma, about on most people. Which line do we want to use? I know it gives you a line. IOML.
IOML parallel to the top and bottom.
So IOML perpendicular to the front edge of the IR. Remember, it's that tricky wording again. So how do you do this? If you have your person turned this line, so IOML needs to be parallel to the IR or perpendicular to the front edge. So that's how we're going to determine how much we lift the chin for this position. We can collimate in specifically to the facial bones if you want to. Remember, we are not focusing completely on the mandible. We have a special projection for that, but we do want to include the mandible in this. I don't like the picture that they used for this one. That first one is figure 11.125 on my page. He's clipping a lot of the facial bones on this one, so I wouldn't use that as your guide. We're going to position upstairs though. Question on lateral facial bones.
So it's basically just like this. side.
Yeah, it's like this forward.
You don't need the back of the
Nope,
skull.
you don't need the back of the skull at all.
kind of similar to like sinuses.
It's very similar to sinuses, yes, very, very similar to sinuses. And we will cover sinuses next week. All right, questions on lateral? Okay, let's roll.
I do have a question.
Go.
So like KVP is like 70 to 80,
Yeah.
and then mass is like 8.
Mass, I would say 8. Yeah, sure. That's a good starting point. I would say somewhere between, I don't know, 5 to 10.
Okay.
5 to 10 for your mass range on a standard good unit.
For the test, you want us to know the structure is best visualized or the pathology reason?
So you will need to know that for your registry, but I will not test you on that.
Okay.
No.
So patient position, part position.
Yes, patient position, part position. Only the specific ones that we talk about, if I tab back to skull, and I think about like the town method specifically, I would definitely know that we use this to demonstrate the occipital bone, and we could see the foramen magnum on this one, right? Specifically, it's going to be a very distorted image because we use a steep angle on it. All right, so the next one is going to be our parietal acanthial projection, which is also known as the Waters method. So a lot of people like to say, compared to a PA or a Caldwell, we keep our head above water. So we go up for this one. So we use a 8x10 or a 10x12. Which ones do you guys use clinically? 8x10 or 10x12? 10x12, probably, right? Know that you can do it at a smaller IR size, so you can use an 8x10 if you want. We're going to keep it portrait for this one. So we're going to maintain the portrait. We are going to position the patient until the MML is perpendicular to the plane of the IR. So where is your MML? Okay, good. MML, so mental meatal line. Mental meatal line. So this line right here, basically, your jaw line. So we want it perpendicular to the IR, so it needs to be raised quite a bit on most patients. Remember, you don't want them looking like this though. It's not going to be SMV. So we want this line perpendicular to the IR. Why do they call it a parietal acanthion? Because that is the direction that the beam is traveling in. So when we talk about projection, we talk about the way the beam travels. When we talk about position, we talk about the position of the body. So since it is a parietal acanthion, it enters in the parietal aspect and exits out acanthion. All right, where is acanthion? Point to it. Acanthion, good. Good. Everybody good with that one, acanthion? So that is where your exit beam. So you don't have a CR for this one. We're going to tilt the MML perpendicular, and we want our exit to be acanthion. Acanthion.
Yeah, I realized I was pointing at here. I don't know.
That's why I asked.
And then the OML.
OML.
37 degrees.
OML would be 37 degrees. Good. So we know since these lines are about 7 degrees apart, I have seen a test question like that before. What degree of angulation would the OML be at if your MML was perpendicular 37 degrees? You're going to count your sevens.
What do you do if they can't?
If they can't extend, you can do a modified or you can do a reverse Waters.
Could you angle the 2
Yeah.
up?
You can, but you can't when you're doing sinuses, so it's specific to facial bones. So it depends on what you're imaging. Good questions. Good questions. All right, so remember we're going to be exiting out acanthion, entering in parietal portion of the skull. 8x10 preferred. You might see it perform 10x12 because they're lazy and they don't want to collimate. We are going to keep our orientation portraits. Questions on this one? Center to the MSP as far as right to left. So center to the MSP. We want to be directly in the center of the skull.
Would you say it's the same mass?
Same mass, yes. Same mass. I would say same mass. Closer to the higher portion because you're penetrating through more than just the facial bones on the lateral aspect. So I would say at least 10 on that one.
So with you said with the reverse,
Mm-hmm.
would it just be like you would do AP instead of like a PA?
Yes.
And then the beam would go
Into the acanthion,
to parietal.
exiting out the parietal portion. Yep. Yep, exactly. You can collimate in on this one, so if you perform it with a 10x12, you can collimate into the facial bones. Remember, we don't need the structures of the lateral border of the skull. We don't need the superior portion of the skull. We're focusing on the face, so facial bones for this one. So feel free to collimate in. They used to call it coning in when it used to be a circle. So you might see that verbiage in your textbook as well. All right, so what is our last one? Caldwell, good. So next page, so tab one page over for the Caldwell. So we're still going to stay PA, but what do we do to our beam and what do we do to our patient?
Angle it 15 degrees caudal.
Good, so we're gonna angle the beam 15 caudal, so put an angulation on the beam, and we change the person's position from MML to OML. So we drop them back down, exiting at nasion. Exiting at nasion. So all Caldwells exit at the nasion, if you want to associate it that way. All Caldwells exit out the nasion. So our center might be, our center or our exit point will always be the same when you're discussing Caldwell method specifically. So we're going to use OML perpendicular. We're going to keep our IR portrait, keep our 40 SID, exit point nasion, tilt the OML to where it's perpendicular. So we're just going to drop the face a little bit. Feel good about it? Okay. All right, next week we're going to talk about sinuses. So I want you guys to take a break because we've been in here for a while talking. So take a 15-minute break, come back at 10:45, and we'll do lab groups and this skeletal system activity to get you prepped for your exam. If you want to grab it, it's up here though.